want to fight with the payers or the hospitals over that premium dollar. When there's global risk, then we should all be sharing, we should all be aligned with the same vision, and who benefits the most? The patients.
Hello?
Go ahead.
I want to take an answer from a different point of view. I don't know how many people in the room are debating whether to join an ACO or not. So from my perspective, I'm a full-time practicing physician. First of all, let me say that the future is great for primary care. I mean, if you're aware of it or not, the codes that are coming out that we are now getting compensated for the stuff we used to do for free. Advanced care planning, transitional care visits, annual wellness visits, all the depression screening. We are getting compensated for what we do better than we ever have before. And if your income is not improving from that, you're doing something wrong. Which is why I think you should join ACOs. ACOs will do two things for you. They'll allow you to have camaraderie with colleagues. For my entire career, I was practicing in a silo. I had a mid-sized practice, and if I had an idea, I tried it out. Okay, it improved care, oh, that didn't work. I bought this hearing machine for like $30,000, and in December and in January, Medicare canceled reimbursement on that code. I was screwed. But when you join an ACO, you've got all these other practices or some administration that is helping you come up with new ideas and ways to help your patients better. When a new code comes out, transitional care visit, or chronic care management, or CPC Plus, I was so busy taking care of patients that I didn't have time to keep up with all the stuff that was coming out. But by joining the ACO, now I'm on the cutting edge of every opportunity I can have as a primary care physician. And in addition, I have data. So I kind of know, sort of from my EMR, what % of my patients have had colonoscopies and what controlled hemoglobin A1Cs I've got. But now I have much better data joining an ACO. So the reason to join an ACO is not so much for the money and the risk stuff, that's all coming, there's no doubt about it, and you're going to have to learn how to do that. But you join it because of the collegiality of it. You're no longer by yourself in your office, however many hours a day you're working, overrun by patients. You actually can sit down and talk to other practices and see how they do it and feel you're part of a bigger picture, not just in your own little closet.
So as a primary care provider, I can tell you I was in a large group practice 20 years ago, working 10 hours a day, 4.5 patients per hour, complete volume. Now, as I mentioned, I'm in PACE, which I consider an ACO on steroids, because we're a full 100% of the premium. So the other benefit and the other why is I have a whole support team now. So when I see a patient, I have a social worker in the office. I have a nurse that's dedicated to just 50 participants. Today in our office, I have a psychiatrist that's there 2 days a week in the office. So having the whole support team. So I agree on the financial side, but the other important aspect of being part of an ACO and the right ACO is the other supportive services to make the administrative burden less on you. And as a result, focus on the things that really matter to our patients and making them healthy. I can tell you 90% of what makes my patients healthy in PACE is not me making the right diagnosis and writing the right prescription. It's what the social worker and the other members of the team are doing. You know, because if I make the right diagnosis and write the right prescription, but they can't fill it, or they can't get food or other things, that's what impacts their health. So the reason to be part of an ACO is that in the volume-based world, you don't have colleagues, you don't have the support staff. The ACO, the right ACO, can give that to you.
Thank you. Jim?
Well, I'm the only non-doctor up here. So, but I played one on TV one time, if that counts. I don't think it does. It's just as a service to humanity, I just stay away from that side of it. But I have been in this business for 45 years. And 35 years of it in the CEO role, mostly in hospitals, from which I'm recovering right now. And going to the primary care side. But you're being in that role that long, you kind of forget how to do anything except for distill everything down into a fundamental. And somebody's got to understand the fundamentals. So I guess that's my role. But whenever I look at the whole thing with the ACO and you look at the Affordable Care Act and the HITECH Act and the state regulations and all the other regulations and the way everything is structured by the health plans, you know, that's really a mishmash of people, for the most part, who have no idea what they're doing. And those who have some idea what they're doing, but there are a lot of conflicting motivations. So you look at the commonality, which we have done in formulating an ACO. Look, it's really hard to paint a vase of flowers on a paint-by-numbers that's designed to make a train. So coming down to the fundamentals, we looked at it and said, you know, from a health plan standpoint, whether it's CMS or whether it's Horizon, do they want to deal with you or do they have to deal with you? And the difference in between those is, one of them is you're just big enough where they got to deal with you. Or the other one is you're adding value to what they have and they want to deal with you. And they're willing to work with you to change the rules and to change the system so that it is mutually beneficial to the health plan, which is primarily self-insured employers, to the physicians who are providing all the services, and most of all, to the one commonality between the employers, the health plan, and physicians, and those are the patients. And if everybody's in a position to win, you can structure accountable care to make it work the way it's going to work most effectively. And within an ACO structure, there's also, whether everybody's under the same tin or not, effectively you have a confederacy. Well, if you have participating providers of a confederacy, if you're under the same tin, you're a federation. But still, it's meritorious. So if you really work within the system, make it work for you as an individual practice, you can really reap some large benefits. If you don't, you have less value. And then you've got an ACO who's making a decision as to whether they want to deal with you or whether they have to deal with you. And to be successful sustainably, and that discussion is taking place, to be sustainable, you have to improve health status over time, which means you have to have high quality. You have to do it very efficiently and effectively, and that means everybody's going to be working on all cylinders all the time. And you can't afford to have practices that aren't going to play along or just do whatever they want. But you also don't want to bring everybody into a lockstep so that they're practicing by rote. This is a very delicate, fine line. And that is why, you know, when we look at our ACO model, just trying to share how we do things, it's been effective to have physicians managing the clinical and the practice side of things, and to have, you know, business people like me managing the business side of things. That's what we do. And it's been pretty effective for us. So we'll see. We've been sustainable and getting shared savings year after year for years now. And if we keep doing it, maybe it's something to look at. But I think all of us in this platform here will have more and more impetus to collaborate and share what works to the common good.
board meeting yesterday. What matters as the CEO is not, did you do all the right things? You're not an hourly employee who checks a bunch, punches in, punches out. As a CEO, you're held accountable for the outcomes you achieve. That's the difference between being a CEO and being a line worker. And I think the question we want to ask our primary care docs is, do you want to be a line worker or do you want to be a CEO who's accountable for outcomes? And I can tell you that those where we can let go of some, and I really want to applaud Steve Peskin and the team at Horizon Blue Cross Blue Shield for really engaging with us now, and with Tom McCarrick of Vanguard, on saying, what if we rethought quality measurement for a world where providers are actually on the hook for outcomes, and what could we do on leading the nation in thinking about quality measurement differently? So that to me is exciting. Once you step up in responsibility, there's a bunch of stuff you can let go of as well. It's not just more on top of more.
That's helpful, and I think just as we keep on this, give everyone time to answer this question, I'd love for you guys to also include that patient in this answer, right? Because so often we hear, but how can I be responsible for the patient that doesn't want to fill their prescription or can't afford to fill their prescription or continues to do whatever it is they're doing despite all my well-intended advice? Because that's part of this equation as well. But Steve, go ahead. Do we have a mic for?
One of the few advantages of flying out of Newark, and they're really very few advantages, is I do get to read 3 or 4 newspapers. So Wall Street Journal Monday, so the Wall Street Journal on Monday had a depressing article about pajama time, and I mentioned it to my colleague in clinic, Joyce Schneiderman, and she said, oh, is that when I talk with my husband in the evening? I said, no, Joyce, that's when you're spending 90 friggin' minutes with your EMR. So I'm wondering what the 5 of you are doing, and it's kind of weird that fancy Stanford and fancy Hopkins have to name chief wellness officers, but they do. I guess they do. And so just the question of how you all are having that impact on that, administrivia, I think is the word. So if you could talk about how you at Riverside and Aledade and Osler and Richard for your group are addressing that.
Before you answer, we're live streaming this, as some of you know. We do this every year, so it would be really helpful.
Yeah.
I hate to make you get up. I can come to you with a microphone, or if you have a question, you can go to the center. Thanks.
So, Steve, I think that goes to the part of the quadruple aim, that the joy of medicine and work-life balance, and really that culture, and empowering the physicians to what was alluded to, where you are now being rewarded not for sick care. Our system should be called sick care because it's reactive, it's fragmented, and it's not integrated. But you actually get rewarded professionally and financially for wellness and prevention, not for intervention when not necessary, or for doing more. So that's an empowering feeling as a physician. And I think what was also mentioned was one of the advantages of joining an ACO or augmenting your infrastructure. However you get that infrastructure support, whether it's capital, human intellect, to measure data, aggregate data, analyze data, and perform well, that really takes the burden away from the practicing physician. It's my role, although I'm a practicing physician, as a co-president, to find the resources, find the support, and make sure doctors, nurse practitioners, PAs go back to practicing medicine. And bringing the joy back that way, and listening more than we speak, and listen to understand, not to reply.
We integrate with 70 different EHRs, and then we do the quality reporting centrally, and we can do A1C greater than 7, greater than 8, greater than 7.5. We don't care. So taking a lot of that burden off. But I think the biggest thing that we add back to providers around the burnout and physicians is meaning and purpose, I think, is the antidote to burnout.
You know, we do all that too, Steve. We had this conversation. If you're a liability, you're going to get controlled, and if you're an asset, you get supported. So we looked at really the fundamentals of where the data comes from, what everybody has to do, and to fill those responsibilities within really what's needed to make everything work. So we just decided, look, we're going to change the rules, and we're going to buy our own EMR company. We'll control the code. We can keep it stable, we can reduce the clicks, and we can purpose build it for value-based care as opposed to just filling in, checking off boxes. So that's our solution.
So I'm going to have to change that. I know this is being live streamed, and hopefully it's not being recorded as well. But I started off by saying we just converted June 1st to Cerner. So Atlantic Care is a hospital system. And as a result, everything tends to be still hospital-focused. So hospitals are either Epic or Cerner for the most part, and they're the ones that typically make the decision and push it down to the provider. So, I mean, I embrace your approach. I mean, I think when you're deciding, and again, the why first question, I think you have to, as a primary care provider, move to this value-based world under an ACO. I think you really need to look at the devils in the details, and the ACO you join has to be able to support you with the EMR, care coordinators and other services to make sure that they're actually making your lives easier and achieving better health for the patients you're dealing with. And I think that's the movement and decision you're going to need to make going forward.
You want to pass it down? Go ahead.
Hello.
Yeah.
I mean, administrative stuff is still a problem that we have not completely solved at Atlantic and Optimus. Two things. Whether you can extract the data from the EMR or not, the data's got to be put in by somebody. We have a strategy of giving 80% of care coordination fees back to the practice to manage it themselves. So hopefully, the doctors are not just putting that money in their pocket, but are hiring mid-level MAs, whatever it might take, to help with the administrative. We keep 20% for our overhead. We also do practice management. So I personally go out to offices, look at their workflows and say, maybe you could do it this way, maybe you could try that way, maybe you can delegate this responsibility. But there's no doubt that as it stands in the world now, the quality reporting is a pain in the butt and takes extra work above and beyond caring for the diabetes and the hypertension and that they just lost their mother.
Okay. Let me just go. All right, let's go to some questions. You can leave.
All right. You've convinced me I should belong to an ACO. Which one? I hear Riverside gives a nice speech, Alliday gives a nice speech, Osler, Riverside. What's different between all of you that I should go with any one of you?
All right. Well, if we're going to do that, we're going to have to do this as a speed dating approach. All right. So let's go this direction.
So
speed.
So we're growing at about 40% a year in provider growth, and I think it goes back to the original thing. So we want seamless implementation, integration, and onboarding to the point where we have a team of about 24 folks that just do that to align folks with us. and why people would want to join Riverside, and whether it's fee for service or in the ACO, it's because we empower them and we have a team-based approach. From all 1,500 folks at Riverside, 250 are physicians. We treat our medical assistants, our nurses, our nurse practitioners equally. We don't have a tiered system. Our delegation of authority is shared, where everybody is responsible, everybody's engaged for patient outcomes, and it's not this autocracy of doctors at the top, nurses at the bottom, MAs at the bottom. Team-based approach leads to higher satisfaction in the workplace. And I would suggest that you ask the patients, and I would suggest you look at the quality and cost reporting, which should be public. But again, I think everybody up here is great as well.
Right.
Independent. Independent. If you want to be independent, but be able to use an incredible world-class tech infrastructure, regulatory infrastructure, practice coaching infrastructure, and you want to stay independent, Aledade.
Ditto, and I'm at a disadvantage because he's better looking.
The one plus for us is no downside risk. So the health system takes all the risk. So if there is any losses, it's not put upon the physicians.
Yeah, I thought I was coming down to just teach people what an ACO is. I'm not proselytizing.
You notice I asked you the easy question, right?
If you want to join us. I mean, we are a great ACO. We've shared savings every single year, but I don't care.
All right.
Well, that last one was gutsy. So my question is a little bit long, so try to bear with me. A lot of the physicians here, particularly those who are in group practice, not related to a hospital owned by a hospital, whatever you want to call it, have had difficulty with doing what they're doing, but we do it very well. PCMH program, Steve Peskin, Horizon, et cetera, for probably about 8 or 9 years ago when we developed that program. And a lot of guys and girls here and physicians and practices get it. The challenge that I see, particularly in New Jersey, is that there's a bridge. While we're doing the best we can do, the payers, excuse me, Steve, the payers are not necessarily on board with what I believe needs to be on board for total cost of care. And by that I mean that there are still things that they are paying for that add to the total cost of care that we have no control over. Now, I go to the hospital. I've been going to the hospital for 34 years, still take care of my patients, my practice does. And the paying for observation and the observation codes is the biggest waste of resources I've ever seen. Anybody who's not, so aware of that, you could basically go into the emergency room over the age of 45 or 50, depending. You could have the vaguest symptoms known to man. They will do a $1,000 workup on you, and the ER doc will be uncomfortable with sending you home for whatever reason, and you will be placed in observation. And the terrible part of that is that the payers pay for that. So we as primary care docs will go in the next day for somebody who was admitted at 2, 3 o'clock in the morning, and we'll send them home around 6 or 7 o'clock in the morning. They've spawned an entire industry of observation units with nurse practitioners who want you to get the patient out soon so that they can turn that bed over again with the hotel industry style. The second thing that the payers pay for that is also very egregious, and CMS pays for this too, it's not just the payers, it's all the payers, is the facility fee. If the hospital purchased my practice, if you want to call it that, they would then get a facility fee associated with that. I own the building. Why are they getting a facility fee? Why are we in private practice not getting, I'll take half of the facility fee, split it, or take their facility fee. That's all part of total cost of care. And we get to the upside and the downside risk, that's a big, big hit. Okay, so unless the payers start to do their part in adjusting total cost of care by not paying for nonsense, we're going to have a lot of trouble with controlling total cost of care in that bridge. The other thing is the bridge should involve us getting paid more for doing this up front. Okay? When we have to provide the resources to get to the shared savings, we need more than $4, $5, $6 per member per month, and then hope there's shared savings on the back end. There's a lot of resources we need to pay for, and belonging to an ACO is one of the ways to do that, no question about that. But at some levels, those of us who are in private practice need the money up front, and it can't be budget neutral. I can't run a practice on budget neutral. We want on day, by month, by quarter, and you guys who are out there in private practice know that this happens. And right now, unless you are, and I don't like to use the term churning, but unless you're seeing an adequate amount of fee-for-service patients, the $5 per member per month or whatever you're getting isn't making up for that. So, and the last one is, sorry.
There's a question mark in here somewhere,
yes.
right?
What do there's a question here somewhere.
Just checking.
What do you guys, and this is really the question I want to answer because the insurance people have to answer the other question, but what are you doing, it's particularly in the state of New Jersey, about the monopolies that the institutions are creating? If I were Horizon and I would go to an institution, and I won't pick one in particular, but 15, 20 hospitals. Well, we'll give you X for this. No, we want X plus 10 or 2 times X. Because if we don't get that, then try to write policies in our counties where we control 12 or 14 counties in the state of New Jersey, okay, without going out of network. So somebody wrote an article a long time ago and said, it's the cost, stupid, and it is the cost. And we don't control the costs that go there, and those costs keep going up, and they pay for things that we are going to be responsible for in the total cost of care. Sorry I took so long.
So, no, that's a lot of good threads there, and I'm going to let the hospitals start on the total cost of care, because I have a feeling this end of the panel, you're kind of preaching to the choir.
There's a lot of stuff there. The only thing I can think of to respond from our perspective, I personally am not involved in trying to influence policies, but we as an ACO have employed hospitalists, SNFists, and ER doctors so that they have a skin in the game to lower hospital costs, ER costs, and post-acute care costs.
So I'll come at it from a few different perspectives. So I spent a year at CMS as a health policy scholar. My background's actually economics, but I work now for a health system. So politically, as you know, the health systems, the hospitals really have strong political clout. I mean, site-neutral payments make all the sense in the world. It makes no sense, to your point, to pay more just because today it's now a hospital-owned doctor's office as opposed to yesterday. And then the observation is another one. So, until you get to a tipping point like a Kaiser, where the hospital is 100% of the premium dollar, then things change. But unfortunately, in today's landscape, the likelihood that site-neutral payment, which we've been talking about for a decade now, and observation stay, and the other part that you didn't point out is the patient really gets hurt in the observation, because if you got admitted, you don't have the 20% co-payment. So, and now CMS's solution to that was that the hospital has to hand the patient a letter saying you're in observation. Because before they didn't even have to do that until the patient got a bill about it. So I think the unfortunate reality is it's unlikely to change because of the way that the deck's kind of loaded, to give an Atlantic City term.
As again, CEO and me coming out, is a practical reality. Is you're talking about a lot of services, and we're talking about symptoms, but one of the symptoms of lane patients, low acuity patients going into the ED at 3 o'clock in the morning, is access to care. That's what they have available. They're scared. They don't know whether it's a heart attack or indigestion for a lot of people. So you really have to look at the kind of resources that it takes to duplicate giving an independent practice the kind of resources to provide telehealth, be open 24 hours a day, to have more hours, to provide all of the things that a larger group practice can provide more efficiently and effectively. So if you really do the math, it's cheaper. And it's not, I've been in this business for a long time on both sides. I don't see it being collusive. I don't see it being corrupt. It's just a practical reality where you got to fill a need, and it's expensive to be open all night. But I think there's some solutions. One of the not solutions is consolidation into behemoths, because it's never good to be a dinosaur whenever the climate's going to be changing. But it's also never good to be algae in the ocean when the climate's changing. You want to be agile, you want to be big enough to fulfill all the needs, but small enough to be able to react and evolve with the system. And that's just the way I see where it's going. I understand the frustrations. Joe, we have shared those frustrations between each other for years, and we're working to solve that in a positive way. There are inequities in the system, but you can solve the inequities by being just the right size to provide all of the services to avoid being a victim to them, or at least most of them.
I do advocate for policy. And one of the policies I advocated for is site-neutral payments. And I was in the White House with the National Economic Council and the Office of the Vice President and the Domestic Policy Council and the Department of Justice talking about those policies. And they are listening. So it's a long shot. Possibly the hospital lobby is strong, but I wouldn't rule it out entirely, because the other thing that we advocated for was that the Medicare Shared Savings Program switch over time from just improvement over yourself again and again and again and again and again to a system where you begin to blend in efficiency. And let me tell you, practices who are affiliated with hospitals, who serve as entryways into the hospital's, MRI machine and the surgical suite and the specialists and all that, right? They will be higher cost than those independent practices. And those independent practices, that armor that they've put on themselves will end up slowing them down. And those independent practices are going to be the ones who get rewarded if you're thinking about this long term. If you're not thinking about this first year, second year, third year, but if you're thinking about this over the long run, those practices who have a lesser number of those obs days, a lesser number of those facility fees, who work with other independent specialists, are going to win out over the long run. And that's a policy issue that we fought for and we won. So I'm not giving up on facility fees either.
To add something, I mean, there was a lot of good points, and I have the unique perspective of being in a hospital ACO, but running an independent third largest ambulatory group in the state. And I also had the pleasure of serving with Linda as co-chair for the governor's healthcare transition team, where we tried to actually enact policy. And one of the examples I would give you, which I'm sure everybody's aware of, there's about 1.8 million people in New Jersey with Medicaid, and there's 9 million residents. So there's a cost driver right there. If Medicaid continues to pay people at 40 to 50% of Medicare, well, then primary care doctors, we're unique because we have the scale to take a loss on Medicaid. We'll make it up in the commercial. It's just our culture. But people that are in our size can't do that. So if there's less primary care access, they will end up in the ER for a runny nose or a strep and probably get admitted for things that they otherwise wouldn't if they can see their PCP that day. And in Linda's Blueprint 2.0, the Medicaid state budget was $15 billion. Do you know how much of that actually went to physicians? 8%. So if that doesn't reveal a big problem, where's the other 92% going? Well, hospitals, pharmaceutical, et cetera, nursing homes. So that to me shows the inherent conflict and problem in the system as one clear example. And 48% of every baby born in New Jersey last year had Medicaid. So who are their primary care doctors going to be? And that's the long-term issue. And an example, I don't want to get into the facility fee issue, but I would think most payers will follow CMS. CMS is pretty influential. Hospitals are pretty influential. But that's where I would talk to Dr. Peskin and other large payers and say, hey, if you want us to perform well as an ACO or go into risk, we need complete and utter cost and data transparency. If my ENT surgeon needs to do a tonsillectomy, you need to tell me where the best outcomes are. I know how my surgeon is, but if hospital X is 50% the cost of hospital Y with the same outcome, I need to know that, or else I'm getting penalized for doing a tonsillectomy at a high-cost hospital if I don't have access to an ASC, for example. So those are kinds of the open transparency that physicians outside of hospitals need. Another example is, I don't know why they pay the same for a C-section and a vaginal delivery. If you really want value-based care delivery, and it's not an emergency C-section, but rather an elective, hey, let's pay people the same, as long as the outcome's the same, unless it's an emergency C-section. And I guarantee the C-section rates in New Jersey would not be the highest in the country, or one of the highest. I'm sure we would then start going to the teens and the low 20s. But, you know, it's easier said than done. But those are some of the examples. And mental health. We have 8 mental health offices. And Dr. Peskin's been very helpful, Susan Kunis and folks. And the reimbursement for a 45-minute mental health visit is laughable for what my psychiatrist, my social worker do to those patients. In a fee-for-service world, we lose money, a lot of money on mental health. But we did it as an investment towards the journey towards value-based care, because when we looked at our hospitalization data, our nursing home data, our readmission data, a lot of those patients, if you want to use the term hotspotting, those 5% had mental health comorbidities. So we figured if we could tackle that now, that's long-term planning. But, you know, if you want to integrate primary care and mental health like we do, the payers have to respect that and also meet us halfway so these people don't end up in the hospital, or, you know, those are unfortunate utilizers of the system that can easily be. And hospital consolidation was your first. I think everybody in this room except hospital system leaders would tell you hospital consolidation cuts costs. Well, the fact is when hospitals consolidate, all costs go up. And it's a tough position for us to be in. What I worry about is all these new graduates, family physicians, graduating residency, these fellows, they can't start independent practices. They either have to join a large system, hospital system, or ambulatory group. So we want to fight like hell to make sure that they, you know, they have their independence and their autonomy by joining us. No offense to any hospitals, but, you know, that's kind of the direction we're going. We're working like hell to get new graduates to buy into our model, because we believe the future of healthcare is not going to be in brick and mortars. It's going to be outside the hospital walls, except for quaternary care.
So Omar's got a 10-point plan here. I'll take a picture and tweet it, and I think it will solve the healthcare problems in the United States. Terry.
Hi.
Good to see you.
You'll be happy to know that my question doesn't last nearly as long as Joe's. Thanks, Joe. Anyway, given the fact that I think we all agree that primary care is the straw that stirs the drink, and that's the future, I'd be interested in your comments. And given the fact that patient-centered medical home is probably one of the emerging vehicles, or in the past, for appreciating what primary care docs do, I'd be curious to know, and also patient-centered medical home, of course, has been notoriously underfinanced by payers. I'd be curious to know your comments about the unfortunate recent data about some of the large trials of PCMH and the fact that their return on investment is not nearly where we'd like it to be, or where I hoped it would be. So I'd be interested in your comments about that.
Okay.
I wasn't surprised. Saving money's hard. You got to be focused on it. It doesn't come across as a byproduct of anything unless you really focus on and are aware of what are the costs, what are the cost drivers, and you're focused on that problem. It's not a byproduct of anything. PCMH is the foundations, I agree, but you got to layer on financial incentives around total cost of care to achieve that and to move beyond the 4 walls of the practice. A lot of the PCMH stuff is within the walls of the practice. And I think, you know, let's take health information exchange as an example, right? Once you start an ACO, like getting hospital event notifications is a must, right? For a PCMH, not really a must, right? But if you want to get good transitions in care, in Delaware, we're getting 100% of the hospital notifications. In Philadelphia, we're getting close to 100% of the notifications. In New York City, we're getting almost all the notifications. In New Jersey, we're not getting hospital notifications. There's something wrong here, right? And if you want to step beyond, you want to get savings, like you got to know when your hospital patient hits the ER, gets discharged from the hospital. So those are the kinds of things that actually begin to matter a lot more when you move beyond the PCMH paradigm to saying we need to take accountability for total cost of care.
Yeah, PCMH is a philosophy. So there are many people I know that are PCMH certified that do not practice PCMH actually in their office. They filled out the forms and they got the certification, but they're not really practicing it. And PCMH is the start, and then you go to the patient-centered neighborhood, which does include coordination of care, work with specialists, et cetera. So Optimus has been one of the most successful ACOs, and one of the prerequisites was that every practice had to be PCMH certified. And I believe it's because it's a philosophy. I am strongly a PCMH believer, but it has to be practiced. You can't just get certified and not do it. And then I think there is success, and it isn't all financial success. The quality of the patient, the quality of the care that you're giving is better if you follow the philosophy of PCMH.
Hi, John Cullen, and I beg your indulgence. I'm not from New Jersey. I'm from Alaska. I'm the president-elect of the American Academy of Family Physicians, and this is my second year here. So the impression I had, this is a wonderful opportunity to come back, but I have to say that the impression I had from last time I was here is that payment for physicians in New Jersey was inappropriately low. And I can tell you this from traveling around the country and going to many states now over the last 4 years. And I think that New Jersey is actually one of the more difficult practice environments that I've encountered, and just for that reason. Can you discuss a little bit about the antitrust implications of being in an ACO in terms of negotiating higher prices?
Well, it depends on what kind of an ACO you are. ACOs aren't necessarily negotiating fees, although that can be a component of it. What you're really doing is negotiating a framework to be rewarded for providing value. Again, assets get rewarded, liabilities get controlled. And if you're a liability, you're going to be controlled with low fees, and I think that's happened in New Jersey. It's a dysfunctional system, and bringing this into line is going to have to be a collaborative effort. And I think the foundation of it, and I also agree, PCMH is not a solution, it's a good foundation. Medical neighborhoods are a step ahead, and the primary care needs to be the mayor. If you build that kind of a structure, and if you build a society, a medical society built around that, I think the value and the recognition of the value is going to come along with it. Does that help?
Great.
I wanted to say I don't feel like a CEO making 5% of the healthcare dollar in New Jersey. I think CEOs make a little bit more. In an ACO, we're all dependent on each other in terms of making shared savings. And in each of your ACOs, what do you do with the bad performers? Let's say I'm not following the culture, I'm dragging everybody down. Do you fire them? What do you do for them?
Yep.
That is a great question. I think that's
Yes.
that's another one we can maybe do a speed answer. But other than just kick them out, what's a path to success? I mean, there's got to be an improvement path, because this is really hard work. So maybe you could talk about that a little too.
We have performance improvement plans. It's the PIP. I can't remember what the second I is. Bottom line is, you don't get shared savings, you don't get commercial coordination care benefits unless you fulfill the PIP. If you didn't do transitional care visits, if you didn't have care plans, if you didn't have your mammogram rate up above a certain amount, et cetera, et cetera. If a practice does not pass, their money is put in escrow. They then have 2 more quarters to rectify the situation, and then they get the money. I must say no practice has not gotten their money, but we have kicked out a few practices at the end of the year.
And Scott, what kind of transparency do you have along the way, and how timely is it?
Full transparency. Everybody can see everybody else's data, but we're sometimes 6 months behind on the data because the claims have to come in, they have to be processed, we have to process it. So yeah, that sucks.
Okay.
I think getting back to your original question and answering this is so why, which ACO you want to join is how they treat you. So whether you're a physician or a practice, use the term practice, it shouldn't be the physician that gets penalized because it's the whole practice that really controls, the aspects of the quality and the total cost of care. So if they're dealing with you and treating you just as a physician, that's who's going to get penalized or kicked out. That's inappropriate. It should be the whole practice that gets trained and educated and moved in the right direction. Our process is over 6 to 8 months for that. So it's not an immediate kicking out of physician. It's really working with the whole practice to get everybody up to speed.
As you know, we have full transparency, and it's really, really important. People join the ACO because of who else is in the ACO, because they want to be in a boat that is a winning boat. And I actually think that ACOs, when they get too large, you get more of those problems. So keeping the right size of ACO, where everyone knows everyone, they can look each other in the eye and they can hold each other accountable, is plus the transparency is the key. If we get more practices, we might create a second ACO where people can hold each other accountable and know each other in that context. So I think that's really important.
No, I agree. You can provide support, and some people are going to take it and some people are not. But ACOs are not for everybody. People are in different stages of their careers. Sometimes they're just geographically disadvantaged. If you're surrounded by a hospital and you're looking to decrease your costs and you're a small practice, I mean, you're a guppy swimming uphill in a rainstorm. It's just not going to work very well. So, we try to help everybody, and I agree. You have to be right-sized, but there are ways to grow an ACO without growing in practices. What you do is just do a better job, and patients come to you, so you can grow that way.
And I would just add, before we talk about what we do with the people not performing well, what's the selection process? Because if you start at the beginning and your due diligence and your selection and vetting is standardized and you have a very high bar, and we always say it's easier to, it's easy to make somebody go from good to great. It's not so easy to make somebody go from bad to good. And I'd rather have somebody who's good consistently than great sometimes. And so if you start properly from the beginning, it goes to everything. And I don't want to underestimate the importance of us, Riverside, being on the same EHR as Hackensack, and how that's allowed us to perform at a very high level, that we both share Epic, and we're one of the unique groups in the outpatient world. And I'm not going to talk about Epic, because this is being live streamed, but I guess it's great, wink, wink. For ambulatory, it's great for hospitals. But, it kind of goes with an IPA model almost. What do you do in IPAs where everybody's under the same tin, but you don't have full control? Well, fortunately, for the last 40 years, Riverside's always been a full employment model. So we believe we have more control over the performance. And I think somebody said it. I give the providers the benefit of the doubt, and I rather look at the structure and the process that's driving outcomes and not the providers, and give them the support necessary to perform at the highest level.
Sure.
Evening. Thanks for coming, guys. Jeff Zlotnick, past president of this organization, and now living in a strange land of strange customs called Pennsylvania. Question is, how does medical education fit in, or even should fit in, with ACOs? I mean, residency programs are not exactly known for their efficiency. They tend to be a little bit on the higher risk side. Is there something that you guys think that they can get involved with, or should get involved with? Kind of like your opinion on that.
Great question. Thank you. Anyone?
Absolutely. I mean, this is the future of healthcare, and that should be a part of everybody's education.
We gathered all the deans of the medical schools and graduate training programs, nursing programs at ONC with David Blumenthal to talk about tech-enabled healthcare. And one of the deans there said, medical education is the only organism known to man without an excretory function. Nothing ever comes out. You just keep adding stuff in. Nothing ever leaves. So the objection there is, something's got to come out, and whether it's all the Krebs cycle and anatomy stuff that maybe we don't use as much, but someone's got to come out in order to make room for, I agree, actual improvement, right? I would love to have medical students come and do a rotation where they do a 4-week improvement cycle. Pick something, pick one thing, and drive practice improvement throughout that. I think I would have loved to have had that instead of a whole bunch of lectures that I never used.
We partnered with Rutgers to do an elective in our pop health department for pre-med and medical students. And Hackensack Meridian just launched a new medical school, and the curriculum is being designed to not only talk about population health, but kind of the business of medicine. I mean, I graduated medical school across the river 9 years ago. I didn't know how to code and bill. I didn't know what was compliance in a fee-for-service world. Yeah. So, one of the things I've stressed being on the admissions committee there is we need to design an innovative curriculum so people also know their options. They should also, a little bit off topic, they should know how to review an employment contract. They should know their options, and I think it goes to the President-elect's point, which I was kind of whispering to Linda, about primary care shortages. And why are there primary care shortages? Well, it has to do with compensation, most likely. But now I think with the alternative payment models and everything we're discussing today, my hope is that we will see more people wanting to go into primary care, and we won't see these shortages when the compensation is more an even playing field and people are more empowered when they understand the importance of what primary care does to the overall healthcare system.
Thank you.
Yeah, we teach about 400 residents a year throughout our 85 sites. And I can talk to you about the curriculums that we do outpatient.
Great. Tom, Dr. Ortiz, good to see you.
Hi. Thank you very much, Linda, for being here tonight with us tonight. We really enjoyed the presentation. Thank you, gentlemen, for bringing your perspectives to the members of the New Jersey Academy of Family Physicians, who, of course, over the past 10 years has been leading the way in practice transformation, not only with PCMH, but just across the board with PTN and so forth. It's fundamental to any of the change that we're going to do in terms of how we even generate a cost savings. That's how we generate. I have two-part question coming, but it's fundamental to the changes we need to make. And I want to thank my colleagues who are in this room. You're preaching to the choir, but I think there's two things that we need to know from these organizations and I think it's very. I always try the doctor to understand that ACO isn't a homogeneous thing. Every one of them is different. Some are structured differently with different folks, so you really need to understand which is the best option for your practice and your location and so forth. Not everything fits everybody. And just because your hospital has an ACO doesn't mean you need to join that ACO. Don't forget, as primary care doctors, once you're in an ACO in the MSP model, you have to stay in there for 3 years, not like a specialist that can change every year. But my question is two things.
You can change. You can switch. 90-day notice.
You can switch. Okay. Is that the new rule?
90 days.
Okay.
90 days.
Well, thank you much for advocating for us, at the federal level, and I think that our National Academy has been advocating very nicely, and it's a great honor to have our president-elect here again this year. I don't know where he went, but it's always great to have our National Academy see what we're doing here in New Jersey, because I think we are doing some cutting-edge things, even though we're still behind the times. But two things. Of your organizations, which one has, or how much have you paid out to your primary care doctors, say in the last 2 cycles? And number two, what do you provide in terms of practice transformation services for your practice members?
Okay, so how much have you paid out, and what other practice transformation services, I think?
Yeah, we have almost 1,000 internists. I think we've given out $80 million over the entire time. That's care coordination and shared savings. Optimus has made shared savings every time. Atlantic has made it once, but I think it was a $20 million savings. As for, what was the second one? Practice improvement?
Practice transformation.
That's what our PIP thing that I was talking about before is all about. We set goals, like for example, the goals now are on care plans and specialist compacts. So we're pushing the practices to do more, integrate the care plans, integrate specialist compacts. We use that, and then we have population managers that go. Each population manager has about 50 practices that he or she goes to help them make their transformation. I go to the practices and give them management consulting. And then we have about 30 people in the office who do care coordination with the offices as well.
So our major transformation is typically having a case manager in the office that we provide that. Our physicians are employed, and we're about 10% higher than in private practice when they come on, primarily because of the ACO and the at-risk contracts that we have.
Well, by the time we're all said and done, we'll have distributed about $5 million, and that's just from last year. And we have a team of people. We're providing analytics. We try to make things task-based because practices do best and function best in a task environment because that's how the system has been built. But I probably speak for all of us. If anybody says they've got this all figured out because it's really only about 5 years old, well, I don't know if anybody can honestly say that. I know we can't. But we're evolving, we're growing, we're getting better, and that's really where the money is going. And if you're going to pick a winner, look for the ones that are really working towards that end. And I think there's some smart people up here.
In terms of services, we provide all the administration of the ACO itself, all the regulatory filings, all that kind of stuff, medical directors, the ACO executive directors, the practice transformation specialists, practice coaches, EHR interfaces we pay for. We have our own proprietary cloud-based Pop Health tool that is a workflow tool for population health. It's not a reporting tool. It's actually a workflow tool. Who do you call? If you're going to call 10 people today, who are you going to call? If you're going to care manage 10 people, who are the 10 people? Who are the people coming in today? What do you need to do for them? You can only get that tool if you're part of our ACO. And all of that comes out of the savings. There's a $1 PMPM membership fee, but our business model is dependent on getting savings for the practices. We don't subtract the cost of our services from the check first before we split it. That's a really important question for you to ask, right? When the check comes in, there was one ACO where they got a $2.3 million check, and they had $2.2 million of cost come out of it. We don't do that. We take whatever the check comes into the ACO, 40% goes to Aledade to pay for all the things that we talked about. It doesn't matter how many years we've been working at this, right? 40% of that check, 60% goes to the doc pool that gets distributed based on how they've done.
Regarding the ACO, I think I alluded to earlier, that's basically for PY 2016, there was over $50 million in shared savings. 75% after expenses went to the physicians, and that was allocated. But how we allocate internally, because we're in 12 other value-based programs with Medicaid, commercial, and Medicare Advantage, we have our algorithm for physicians that rewards them for their performance. And away from the financials for practice transformation, some of the things we do is we have a transitional care team that basically contacts all hospitalists. We have our own hospitalist program at 6 hospitals that don't wait for the patients to get admitted. They touch the patients in the emergency room so we can impact the flow throughout the hospital. We have 12 nurse navigators. We have a Pop Health data analytics team, and we have our own Epic builders in-house. So if we want to customize or change the ambulatory build to meet new star ratings or to help us with CPC Track 2, we do that on site. We don't wait for a third party to help us with that. And we do continuous education on utilization management, RAF scoring, and we continually stress that all the work and hard work continues when the patient leaves the exam room.
And I think somebody alluded to hours. We open till midnight in 4 counties. We have the longest primary care access in the state. But even after that, we continually engage patients. We do home calls on those 5% of the hotspotters too.
So thank you. I'm looking at Sandy and Ray. One more, or do you want them to?
Dr. Peskin.
All right. Okay. All right.
So,
2 questions.
Stephen Peskin, Horizon Blue Cross, and Rutgers Driverwood Hudson Medical School. I love clever metaphors, so I'm going to reference both of them. One with a quick comment to Farside's and about medical education. And Sally, we still miss you at Chandler. So the extracurricular function thing, God bless Renita Sharman, Pyle Dave, and Laura Willett. I don't know how the hell they do it. Internal medicine has gone friggin' crazy with the AC. I mean, all the boxes they have to check. It's ridiculous. But thank everybody in the room for teaching, and I sincerely mean this, all of you teach medical students and interns and residents and primary care specialties, emphasis on the word specialties. So the second one that I loved was the CEO metaphor. And I just looked at the income of some CEOs that were made nameless of certain biopharmaceutical companies resident in New Jersey.
Careful.
So my question,
this is dangerous territory for you.
So my they're clients. So the question is, Spinraza at $1 million per patient year, Car at $700,000, give or take. The pharma costs are going to exceed the hospital costs very soon if they haven't already. So what are Linda, I want you to answer this one too. I'm putting you on the spot. So what are the 6 of you kind of thinking about, looking at? What should we be looking at? And I think on the medical education, that would be a topic for a whole separate conference.
Well, I'll take the medical education one because this is a little personal promo. We have a document over there that I brought from Princeton, New Jersey here today called a end-of-life care strategic plan for the state of New Jersey. I'm sure all of you as primary care providers are aware of how much better New Jersey could do on end-of-life care here in New Jersey. We don't get the outcomes that patients say that they want. We have too much intensive care at the end of life. So over there we have a plan, and one of the suggestions is that the medical schools here in New Jersey do what the 5 medical schools in Massachusetts and the nursing school in New York is doing, which is to create a comprehensive aligned curriculum that they all work on together to make this part of the next generation's education. And there's a lot more in there too, but that's the medical school one, so punt it to you.
The second part of the question?
Yes.
Oh. Which one? Steve, for the second part of your question, everybody here provides pretty much the same kinds of services, but I think the focus is, and the least expensive thing that you can buy is the one you don't have to buy. So improving health status, focusing on chronic care and either slowing, stopping, or reversing its progression, and equipping, enabling, and empowering primary care physicians in particular to get that done is what's going to help to ultimately control costs going forward.
In terms of medication costs specifically that you mentioned, we have a pharmacist. We've developed analytics to identify outlier spending by prescriber as well as by pharmacy. We've identified some pharmacies who had a lot of dispenses written, type 3 switches that they were doing, and we had those conversations with them, with the primary care docs, to say, why are you switching patients at such a high rate, and that has a certain impact. We're able to incorporate brand generic switching opportunities, which are pretty now, there's a relatively small number left, but we're able to incorporate that again into the workflows at the point of care. Where I think we have to go ultimately is to bring in selective specialists who are, the rheumatologist, the ophthalmologist for macular degeneration in the MA population, which is a huge, cost driver. Bring them into financial alignment with the primary care docs, and that's what we're going to be experimenting with.
The one thing that we do, which is kind of interesting, is that we have pharmacists as part of the team. So we actually pay them per member per month, and they provide an initial review every 6 months and changing condition and as needed. So that's one of the things that we've done to be able to control our pharmaceutical costs.
Yeah, we have not concentrated on pharmacy as much as other things because the Medicare shared savings is not related to pharmacy, but as we're hitting our commercials, we also have pharmacists. The problem obviously is that really skews the data is the high cost rheumatologics, the oncology costs, and a lot of times there are not options that the specialists are comfortable going to. So I don't have a good answer.
We part of our provider performance reports on how our providers are evaluated some is generic prescribing rates. So our generic prescribing rates across the board, including our specialty divisions, is at 87% for 2017. And we do seminars on efficacy and safety, and we really focus on our specialty physicians, our rheumatologists, our pain management to drive down those costs. And we've worked with Horizon Ventures to implement technology where all that data would be interfaced directly for the provider to understand basically the out-of-pocket, the in-pocket, and the premiums that the payer and the patient would know, because sometimes they don't know, especially some of our newer physicians. So again, it goes back to education and training.
Okay.
So I think I'm the last question. Most of these plans look at how you improve over time. What happens to the point you got to, I can't improve anymore, I'm already at the top 5%, and we're ratcheted and ratcheted and ratcheted. What have you done in terms of contracting to reward the best performers who are being penalized in a system where the poor performers actually do better with their deltas?
So I'm going to... Well, go ahead. I was just going to say, I just read an interesting article in Health Affairs that was by Sean Cavanaugh and Farzad, and you were talking about a regional approach, which I thought was, a great idea. So maybe you want to share that in your answer, and then we'll go that direction. And come back.
We talked about having the framework for principle-based framework for negotiating with health plans, of saying, what are the goals of this? What are we trying to get to? And one of the goals is sustainability. And in our negotiations with commercial payers, and honestly, you don't negotiate with Medicare, but you can influence policy. We've made that point successfully, and I think our contracts reflect that understanding that you can't keep ratcheting performance down, 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 down. You have to begin to blend in a component of attainment and efficiency over time, because maintaining, a great 95th percentile performance is not easy, as you know. So that's been something that we are strong believers in. But again, getting on the same side of the table with the payer, with Medicare, with Medicaid, and saying what are our shared principles that we can agree to first, and then based on those principles, how do we negotiate agreements?
Okay. Sorry about that, Scott. Go ahead.
That's okay. Our commercial contracts are based on regional standards. So if we have Aetna, we're not fighting against ourselves, we're fighting against what the average Aetna patient costs Aetna each year compared to what our Aetna patients cost. So we've solved that problem.
I think the eventual solution to the problem is either becoming the payer, like we do in PACE, so we have all the premium dollars or getting a percentage of the premium dollars. So the high performers always have a significant delta that they're not fighting against themselves.
Look, the better you get, the more equipped you are to take risk. And you need to be on that trajectory every year. So yes, we all strive to get better. We all do get better at what we do. And you can keep the delta increased between budget and cost by just taking more downside risk, which you're better prepared for.
Okay, well, please join me in thanking our panelists.
Linda, some housekeeping. First of all, on behalf of everybody at NJFP, leadership, staff, membership, Linda, thank you for your help and your great work tonight. I'm told that, thank you, Linda. I'm told that Farzad will be available to tell anybody that needs to know where he got his clothes, in case you want to be as snazzily dressed as he is. And tomorrow morning, folks, for those of you who are interested, the House of Delegates is next door, and we begin at 8:30. Those of you who come every year, you are welcome. We started early, and you get to go to dinner. Good night.